In our trial, we didn't have patients with CD4 count less than 50. And that's just because the logistics of getting people screened within a 2-week window. So the international guidelines now, and this wasn't the case before, but in the last few years have been that you start people on antiretroviral treatment within 2 weeks of starting their TB treatment if their CD4 count's less than 50. So it gives you a pretty narrow window after someone starts TB treatment to get them on antiretrovirals. We didn't think we'd have enough time in 2 weeks to get all the screening stuff done. So back when we planned this trial, it's been some years ago, but so people with CD4 count less than 50 were not included. So I think that's an important group because those might be the people who might be more commonly getting iris. So I think the less than 50, less than 100 CD4, looking in some sort of pharmacovigilance way at those patients, how commonly do they have adverse events? How should they be managed? Things like that will be helpful for clinicians so they have some guidance. I think we need to test the regimen in children. There is one protocol run by Penta in which they're looking at dolutegravir dosing in children, and they're allowing kids with tuberculosis to be enrolled in that, but the numbers are small because it's not TB focused specifically. So I think children is a gap. I think pregnant women are a gap, and but I think that's where we should put our our resources and our patients and our expenditures are into these particular subgroups to make sure this will work for everyone.